Good evening, dear doctors. I'm Badisha, Regional Sales Manager of Azelnidipine Pharma. We are so excited to see you all here this evening. On behalf of Azelnidipine Pharma and myself, we would like to welcome you for this continued medical education program. Today, we will discuss about a new calcium channel blocker, Azelnidipine. So these are the calcium channel blockers available in India. As you know, nifedipine and amlodipine is acting on L type of calcium channel, and cilnidipine is acting on L and N, and afanidipine and azelnidipine is acting on L and T type of calcium channels, and benidipine, this is acting on L, N and T type of calcium channels. These are the different types of calcium channels and their locations. L type of calcium channels, these are present in the skeletal muscle, smooth muscle, brain, adrenal gland. And N type of calcium channels are present in the brains and nerves. And T type of calcium channels are present in the heart, brain, adrenal gland, liver, afferent arteriole, and also in the efferent arteriole, and also in proximal and distal coronary tubule. Now, when we are blocking this, what is the clinical significance when we are blocking it? So in the heart, there is, when we are blocking L type of calcium channels, for example, when we are giving an amlodipine, there is a decrease in the contractility in the heart. At the same time, there is increase in the pulse rate and increase in the glomerular pressure. The reason why we will discuss in the coming slides. So when we are giving N type of calcium channel blockers, there is decrease in the heart rate, decrease in the pulse rate, and also there is decrease in the glomerular pressure. And T type of calcium channel blocker, there is a decrease in the heart rate, decrease in the pulse rate, decrease in the glomerular pressure, and also there is decrease in the aldosterone release. So aldosterone stimulates sodium and water retention that increases the blood pressure, as you know. As per the Journal of Renin-Angiotensin Aldosterone System, high circulating aldosterone level also stimulates myocardial fibrosis and also left ventricular hypertrophy. And the European Journal of Heart Failure says aldosterone promotes sudden cardiac death. Aldosterone causes endothelial dysfunction that causes acute coronary events and also causes sudden cardiac death. And aldosterone causes myocardial fibrosis that causes arrhythmias that causes sudden cardiac death. And aldosterone causes endothelial dysfunction that causes baroreceptor dysfunction that causes arrhythmias and again sudden cardiac death. Aldosterone causes potassium and magnesium loss that causes arrhythmias and also sudden cardiac death. As per the current hypertensive review, aldosterone has recently been recognized as a factor for increasing renal diseases, and its secretion from adrenal gland is mediated by D type of calcium channels. So the D type of calcium channel blockers are the mediator in the release of aldosterone from adrenal gland. So the D type of calcium channel blockers were shown to improve the renal dysfunction by suppressing inflammatory process and renin secretion. So azelnidipine, this is blocking the T type of calcium channels since it is a mediator in the release of aldosterone from adrenal gland. Therefore, by blocking these T type of cells, there is a reduction in the aldosterone release. This is from atherosclerosis 2011. The association between aldosterone-induced antihypertensive medication and arterial stiffness reduction. This is from JCO study. The excess aldosterone has an adverse effect on large artery stiffness. And azelnidipine reduces the production of aldosterone compared to all other L type of calcium channel blockers. And azelnidipine could control hypertension without decreasing the cerebral blood flow, especially in the post-ischemic stroke patients. So in chronic stage of ischemic stroke, azelnidipine could safely decrease the systemic blood pressure without decreasing the cerebral blood flow. This may be the reason why we are getting this azelnidipine is very well accepted with the neurologists. And in the baroreceptors, as per the American Journal of Hypertension, the sympathetic nerve system activity is increased in the patients with essential hypertension. So the patients with hypertension, there is increase in the sympathetic nerve system. Possibly as a result of decrease in the sensitivity of arterial baroreflex. The increase in sympathetic activity can lead to left ventricular hypertrophy and also the development or progression of atherosclerosis. So the barrel-reflex regulation of heart rate also contributes to the spontaneous control of blood pressure even after rest. This is at-home study from the pharmaceutical 2010. Around 2,500 patients were screened here for around 16 weeks, and their blood pressure was monitored in the morning and evening. And the result is barrel-reflex sensitivity is decreased with the age. Azelnidipine exerts both barrel-reflex sensitivity improving effect and also suppressing effects on sympathetic nerve activity. So Azelnidipine has action on both decreasing the sympathetic nervous activity and also improving the barrel-reflex sensitivity action. Again from at-home study, the baroreceptor sensitivity restoring calcium channel blocker, that is Azelnidipine, significantly reduced age-related increase in the morning BP, and also has some potential benefit on cardiovascular protection in hypertension. This is from Journal of Cardiovascular Pharmacology 2007. The impaired barrel-reflex sensitivity can result in the grade 10 fluctuation of BP and is independently associated with poor cardiovascular prognosis. And it's with Azelnidipine and not with amlodipine or cilnidipine that increase the baroreceptor sensitivity. And the reflex tachycardia. Nitric chronotropic effects of Azelnidipine was almost 5 times more potent than that of amlodipine. This is from Hypertension Research 2003. The Azelnidipine and amlodipine. It's a comparison with amlodipine and Azelnidipine. A comparison of their pharmacokinetics and the effect of ambulatory blood pressure. Azelnidipine 16 mg and amlodipine 5 mg was administered for 6 weeks. So both the drugs were shown same BP reduction because amlodipine is also a good BP reduction. But Azelnidipine was found to decrease the pulse rate, whereas amlodipine significantly increased the pulse rate. This may be because of this one, because only Azelnidipine is improvement in the BRS is there. And also this decreases the sympathetic nerve activity and also improve the baroreceptor sensitivity. So therefore there is decrease in the heart rate. That is the reason why there is no decrease. The patients with amlodipine, there is increase in the heart rate. And in the kidneys, as we discussed in the first slide, this N type of calcium channels are present in the afferent arteriole, and in the efferent arterioles, N and T type of calcium channels are present. Since amlodipine is only acting on afferent arteriole and there is no action on efferent arteriole, therefore intraglomerular pressure is there. This may be the reason why there are a lot of edema chances with amlodipine. The glomerular pressure is more with N type of calcium channels because this is only dilating the afferent arteriole. There is no action on the efferent arteriole. So the calcium channel blockers acting on the T and L, there is renal protection and the chances of edema is also very less. This is from Blo's work. The effect of T type of calcium channel blocker on renal function and aldosterone in patients with hypertension. This is a systematic review and meta-analysis. So the T type of calcium channel blockers are better than L type of calcium channel blocker and reduces the glomerular pressure and protecting the kidneys. The reduction of glomerular pressure is a principal strategy in reducing the proteinuria in the hypertensive patients. And from drugs research and development, inhibitory effects on Azelnidipine tablet in the morning hypertension. Azelnidipine is 17 times more lipophilic in nature comparing to amlodipine. The antioxidant effect of a new calcium channel blocker Azelnidipine in cultured human arterial endothelial cells. The antioxidant activity of Azelnidipine is also superior to all other CCPs like nifedipine, validipine, penidipine, icabodipine. Many dipines which are not even available in India. So the antioxidant activity is better with other CCPs. This is from International Heart Journal. The effect of switching from the patients from Azelnidipine to Azelnidipine. So Azelnidipine inhibits the sympathetic nerve activity of the central system. And cilnidipine inhibits the sympathetic nerve activity in the peripheral system and Azelnidipine inhibits sympathetic nerve activity in the central system. These are the main difference. And Azelnidipine inhibited the cardiac sympathetic nerve activity more strongly compared with cilnidipine. We discussed amlodipine is present in the L type, so therefore there is a pedal edema, no sympathetic or action is there, therefore there is increase in the heart rate also. And cilnidipine only peripheral action, there is no sympathetic central nerves action is there. The effects of Azelnidipine, the autonomic functions and its influence on arterial stiffness. This is a comparison with the Meridipine. Azelnidipine has greater beneficial effects on autonomic functions than Meridipine, despite a similar degree of reduction of blood pressure by the two drugs. Both the drugs were showing similar BP reduction, but the autonomic functions was greater with Azelnidipine. This is the comparison with amlodipine. The systolic blood pressure with amlodipine and Azelnidipine are the same. And the diastolic blood pressure we can see is a little better with Azelnidipine comparing with amlodipine. But the main important thing is the heart rate, because with amlodipine there is increase in the heart rate, whereas Azelnidipine decreases the heart rate. Because the action on sympathetic nerve system, Azelnidipine decreases the sympathetic nerve activity and also increases the baroreceptor sensitivity. That's it, because amlodipine doesn't have any action on sympathetic nerve system and improvement of baroreceptor sensitivity. Therefore, there is increase in the heart rate with amlodipine and there is decrease in the heart rate with Azelnidipine. And the limitations of amlodipine, especially in the heart rate, there is no decrease in the heart rate. The reason is that it's not acting on sympathetic nerve system and the renal protection. Because amlodipine is only L type of calcium channel blocker, and this L type of calcium channels are only present in the efferent arteriole. There is no action on efferent arteriole. Therefore, there is intraglobular pressure. Therefore, renal protective action is less with amlodipine and adrenal gland. As we discussed in the previous slide, T type of calcium channel blockers are the mediator in the release of aldosterone from the adrenal gland. Since amlodipine is L type of calcium channel blocker, there is no action on adrenal gland, so there cannot be reduce the secretion of aldosterone. So if you are placing Azelnidipine in this slide, means we can see that there is decrease in the heart rate because Azelnidipine decreases the sympathetic nerve activity, also improves the baroreceptor sensitivity. And in the renal protective and in the globular filtration, we can see that Azelnidipine dilates both efferent and efferent arteriole because T type of calcium channels are present in the both efferent and efferent arteriole. Therefore, intraglobular pressure is less and edema chances are also very less. And T type of calcium channel blockers are the mediator in the release of aldosterone from adrenal gland. By blocking these T type of calcium channels, we can say that there is very much decrease in the aldosterone from adrenal gland. This is the innovator brand Daiichi Sankyo from Japan. This company has invented many drugs, many big brands in the world, just like Tetracycline, Olmesartan, iron sucrose. A lot of n number of big brands that are invented. Again, coming with Azelnidipine. The dosage part is 8 to 16 mg once daily. We can start with 8 mg and we can titrate it to 16 mg. The maximum dose is 16 mg. It's better to take after the breakfast. And the side effect part is 1% of headache is seen. That's all. Any doubts you can just